Okay, well, thanks very much. I assume people can hear me because I was able to talk to Liz just a second ago. So I want to talk to you about the ethics of what we call love drugs, and I'll have to say what that means. But first, I just want to acknowledge that these ideas were really co-created with Julian Savulescu, who's the Uehiro Chair of Practical Ethics here at Oxford. And a lot of what I'll be saying today is derived from this book. This is the UK version called Love is the Drug, The Chemical Future of Relationships. So like a good philosopher, I'll start with a definition. What is a love drug? We want to know what we're talking about, what falls under the scope of this term. And maybe it's a bit of a cheeky definition, but basically it's just drugs that affect love. So I want to break that down a little bit further, and we can first ask, what's a drug? Now, we tend to have these stereotypes in our mind of different kinds of drugs. We might think of recreational drugs as one kind of thing, and then we might think of chemicals that are used for medicine as being somehow a different kind of a thing. But the point I want to make here is that, I think there's a loud noise outside, sorry about that. A drug is just a chemical, and it's often thought of as maybe a subset of chemicals that are relatively easy to take into the body, whether by ingesting or in some other way that has a recognizable physiological or psychological effect. But drugs are just chemicals, and that means that so-called recreational drugs and drugs that are used for medicine share this underlying property of being chemicals, molecules that affect our subjective states and affect our bodies in certain ways. And whether we categorize a drug as being medicine or as being something else is often due to political and historical factors or our values, what we think ought to matter. And it doesn't always have to do with what are the exact effects of the drug. Now, what is love? Okay, that's a big question. And there are different ways of defining love philosophically. And Julian and I have adopted a certain framework for understanding love in our own work. But rather than going into a deep dive into the philosophy of love, I want to make an easier claim, which is that we might just talk about drugs that can affect our romantic relationships more broadly. So sometimes when people hear that a drug might affect love in some sense itself, they feel like that's a very lofty claim, and love is maybe this abstract concept, and it's hard to see how a drug could affect something so abstract as love. But let's just step back and think of a more accessible idea, which is that it's certainly the case that chemical substances can affect our romantic relationships with a partner. And I want to give you some intuitive ideas of how that might actually work. So here are some case studies that come from the published literature. This is from a chapter that's about the effects of basically antidepressant medication, or SSRIs, which means selective serotonin reuptake inhibitors. This is the most common class of drug that's prescribed for purposes of treating depression and also anxiety. And these authors have suggested that these drugs, due to the way they influence our romantic neurochemistry, may have implications for interpersonal connections, not just our private symptoms of depression. So one well-known side effect of SSRIs is that in something like 20% of cases, they can have a depressing effect on libido. They can dampen a person's sex drive. So insofar as a sexual connection with one's partner is important to the relationship, and some people might think that it's constitutive of romantic relationships or something that makes romantic relationships different from other kinds of relationships, you can sort of see in this very blunt way how at least some drugs could have a pretty significant effect on relationships. So consider the following real-life story. There's a 26-year-old man who had panic attacks that required a very high dose of an SSRI. He soon experienced diminished libido and impotence, a handsome, personable, intelligent man who was readily sought after by women. It's a very heterosexual context here. However, he ended several relationships because he was too embarrassed about his inability to perform sexually. He tried other medications, but was able to control his panic disorder only with high doses of this drug. Eventually, he retreated into a social life in which he avoided serious dating. When last evaluated, he confined himself to non-sexual relationships. So that's just a very blunt, maybe overly obvious example of a way in which a very widely prescribed drug, which in this case is used for medicine, can have implications for relationships. Now, another side effect of SSRIs that some people report is not just that it has this dampening effect on what might seem like a physiological, low-level bodily attribute like one's sex drive or libido, but it can have this effect of really blunting our ability to access our own emotions. And so the intended effect of the drug might be to dampen our chronically maladaptive feelings of sadness, let's say. And for some people, it has that effect. But others report that it also seems to blunt their ability to care about the feelings of other people. Now, if you think of one common definition of love, which is that at minimum, it requires dispassionately caring about another person and wanting to promote their well-being and flourishing for its own sake, you can imagine that if you're somebody who takes a drug and you're in the subset of people who find that it prevents you from actually actively caring about the feelings of your partner among other people, that might actually have a pretty serious effect on your ability to love them, according to a common philosophical definition. So consider this case. After 2 bouts of depression in 20 years, my therapist recommended I stay on serotonin-enhancing antidepressants indefinitely. As appreciative as I was to have regained my health, I found that my usual enthusiasm for life was replaced with blandness. My romantic feelings for my wife declined drastically. With the approval of my therapist, I gradually discontinued my medication. My enthusiasm returned, and our romance is now as strong as ever. I'm prepared to deal with another bout of depression if need be, but in my case, the long-term side effects of antidepressants render them off limits. Now, you might be thinking, well, this is just one case study. This is an anecdote. It's not scientifically demonstrable that it was the drug that actually caused the weakening of the romantic feelings, even though by going on the drug, the feelings weakened, and upon going off the drug, the feelings returned. So there's some amount of evidence. And that's exactly right. So part of what we call for in this book is a systematic, rigorous evaluation of the interpersonal effects of commonly prescribed medications, so that we don't have to go off a collection of anecdotes like this where we don't have the strongest evidence of what exactly is happening. But part of what we argue, and as I'll stress in a moment, is that so much of kind of standard Western medical models focus on individuals and their symptoms. But the point we want to raise here is we use a lot of drugs in society as medicine. They're very commonly prescribed, but we don't tend to measure their interpersonal effects on how they influence us in the context of our social relationships. And yet, none of us is an island. All of us are embedded in complex webs of social relationships. And so if we're going to take drugs or prescribe drugs that affect our neurochemistry, that plausibly has implications for our relationships, at the very least, we should know what we're doing. We should go into this with our eyes wide open. Now, I don't want to suggest that there can only be negative effects of a drug on a relationship. In some cases, a side effect of a treatment for depression may be that it improves a relationship. So here's an example from Elle magazine from 2012. Before they got on antidepressants, Susan's tendency to rail at length about whatever happened to be irking her exacerbated Will's extremely self-critical tendencies. Whereas in her depression, she'd tend to lash out. In mine, I'd tend to sink inward, he says. We were heading down a very bad path. Now, though, they agree that their marriage is much more balanced. Susan's rough edges have softened, as Will puts it. And with this, plus the boost medication has given his own confidence, he's become more forthcoming. They're able to work together to solve problems. We really are each other's best partners, Will says. To call us soulmates, I think, would be accurate. So this is very interesting. Now, there's a big debate about the evidence in favor of SSRIs being very effective in treating depression. But there's no doubt that for some of the people who are prescribed these drugs, they can really alleviate the aspects of depression that are preventing them from engaging in their relationships. And so you can see how if you're one of the subset of people for whom these drugs work as intended, then your ability to just get out of bed, for example, and engage with your relationship might well be something that's fostered or facilitated by the intended effects of the drug. So I just want to make some quick preliminary points here, some of which I've already alluded to, which is we have good reason to suspect that certain drugs that are already in widespread use, and I'm just focused on the example of SSRIs, but there are others like hormonal birth control, for example, are having potentially serious effects on our relationships, including what we focus on, our romantic relationships. But we don't really have systematic knowledge about what those effects are or the precise conditions under which they arise. We just know that they do arise and can take many different forms depending on the details of a relationship or how a person happens to respond to the drug. And so our baseline argument in the book is we have an ethical obligation to shift our focus from an overly narrow concern about just individuals and their symptoms, which we then might measure in a clinical trial and see whether this drug has the intended effect, to measure all the effects the drug may be having on the people who take them, including the effects it may have on people in the context of their relationships. And we might also want to then think even more broadly about not just what are the interpersonal social relational effects of drugs, but how does this affect us in the context of society? How does the widespread use of drugs affect our social relationships more generally? And so, again, we have an obligation to study these effects because they're happening whether we study them or not, so that we can avoid the worst dangers that drugs may be posing to the quality or the health or desirability of our relationships. And potentially, we might harness the effects of some of these drugs to positive ends. We might think that there could be a useful role for some drugs in actually improving our relationships if they're used in the right way. And if we do this with our eyes wide open. So you may be aware of what some people are calling a psychedelic renaissance, which is where certain drugs that are right now mostly associated with recreational use, such as MDMA, which is not strictly psychedelic, but is sometimes lumped together with psychedelics like psilocybin from magic mushrooms. Well, these drugs are now being brought back into mainstream medicine as a adjunct to psychotherapy for very serious conditions like post-traumatic stress disorder. And again, in the book, we say the same point, but even more strongly. These are very powerful drugs. MDMA is an extremely powerful drug, and psilocybin is an extremely powerful drug that can have profound effects on our mental states, on our motivations, on our feelings, but also how we relate to other people, how we engage with our partner, how we experience love with another person. And so this is something that, again, we need to be studying the interpersonal effects. Now, we started out this project by trying to just understand descriptively what are the effects of various molecules on our relationships. And then we had this idea that if we understand how the neurochemistry of love works, this would open the door for potential technological interventions into those brain systems. We could sort of manipulate our own neurochemistry for better or worse, to either improve or our relationships or potentially harm them, to either bring love into existence or perhaps degrade love or cause us to fall out of love with someone on some properly elaborated account of love. But what we think is important to always bring alongside discussions of what's scientifically sayable and what's technologically feasible is what should we do? What are some ethical arguments we can make about the right thing to do with these powerful technologies? Now, in our initial work, we tended to focus on rather narrow cases. We would identify a specific kind of a couple, and we would imagine what might be going on for them. And then we would say, could it be ethically permissible or perhaps prudent or desirable for a couple in this very specific situation to potentially undergo MDMA-assisted psychotherapy together as a couple? And then we tried to come up with some arguments where we could say, yeah, it seems like for a couple in this specific situation, that might be a good idea. But of course, you know, this was like we were coming up with these trolley problems for the heart, where we were trying to, you know, come up with a very specific stylized case where we could filter out all the complexity of too much variation and just come up with a, you know, an abstract concept of what would be an appropriate use. And that's one way that ethicists often approach a complex case, is by simplifying and getting down to what they think are the core ethically relevant features of the case. But of course, it's also important not just to focus on stylized concrete examples or abstract examples, but to think about the wider social implications of potentially disruptive technologies. And so in our later work, we tried to really think through what are some of the wider social ethical implications of bringing drugs into romantic relationships, either as a side effect of currently used medications or potentially through these new psychedelic-assisted psychotherapies that are increasingly being studied. And so a big general ethical worry that people may have is that if we start to introduce drugs into the world of relationships, this might lead to the medicalization of our relationships. We might think that drugs that we consider to be valid in our society are the subset of drugs that we call medicine. And so when we call a drug medicine, we have to have the medicine be treating something. That's part of the concept of medicine. And if that's true, if we find that a drug can help people in their relationships, potentially have a better relationship, because of the way that we distribute drugs in society and the way that we categorize them, we might then be motivated to come up with some sort of disease category or disorder category where we think, well, you have, you know, commitment phobia or something like that. And then we can pretend that's a medical diagnosis and now we can treat it with the drug. So the risk here is that you then start subsuming the complex reality of human relationships under the disease categories of medicine, which some people think just seems deeply inappropriate. So here's one way of expressing that. Many people have reached the normative conclusion that they do not want to live in a world where increasing swaths of human experience are under the logic of medicine. There are, or should be, experiences that use an older logic, which are under the jurisdiction of another profession or under no jurisdiction at all. And to illustrate this point, the author from this paper says, we can all fear the medicalization of love. So what exactly is it that we can or might or maybe should fear when thinking about the medicalization of love? Well, there are a couple of different ways this can break down. One is a concern that I've just mentioned. It might lead to us pathologizing areas of our life that formerly had been seen as outside the domain of medicine. We start thinking of love disorders or something like that as a way of justifying our use of certain medications. This could be linked to a general concern also about the expansion of medical social control. Medicine seems to be pervading and influencing ever more swaths of our lives, and maybe we don't want that. Maybe we want to turn to poetry and philosophy and art and music and literature and all sorts of things apart from just the categories that medicine provides us for understanding our experiences. Another problem with medicalizing complex phenomena is that it tends to lead to a narrow focus on individuals. Medicine tends to treat individuals in their circumstances, whereas it may thereby ignore the wider social circumstances of a given problem, because that's not really within the domain or the skill set of medicine to address. Similarly, or relatedly, medicine can often focus not just on individuals, but more specifically on the biological aspects of individuals, and ignore, for example, psychological dimensions of their experience, turning everything into something about brain chemicals rather than thinking about, the more complex, multidimensional aspects of love. And finally, some people are worried that there's a threat to authenticity. So just to illustrate this, if I am taking a drug that is part of the explanation for why I feel love toward my partner, some people would say, is that really love you're feeling? Is that love coming from you? Is it an authentic expression of your soul in some sense? Or is it really the drug that's doing the work? Is drug-mediated love really authentically love, or is it some sort of pseudo-love, some sort of chemical medicalized love? And that's a concern that some people have as well. So to round toward the end of the talk here, I'm going to focus just on these two particular concerns that are related: the narrow focus on individuals that can come about through medicalization, and the narrow focus on biological considerations. Peter Conrad is a sociologist who has done a lot of the most salient work on medicalization. He has an important book called The Medicalization of Society, and here's a quote from that book. Medicalization can obscure the social forces that influence well-being. For example, by focusing completely on the neurobiological features of some condition, it might be seen as a genetic or a biological problem and thus treated predominantly with drugs. There's another author, Barbara Wootton, who has expressed this concern in a really powerful way. It's just a short quote here, but I want you to kind of take in the full implications of this quote. She says, "Always it is easier to put up a clinic than to pull down a slum." Now, there's a lot packed into that quote, because part of what she's saying is, when you address something with medical technologies, it's not just that you may ignore the social dimensions of the problem. It may be that you actively disincentivize addressing those social problems, because you may have a sort of workable solution, something that at least addresses the symptoms enough that maybe people cease to be motivated to deal with the wider problem, which in this case might be people living in a slum, let's say, without adequate access to resources and to good housing and to other environmental factors that influence health. On the other hand, if you aren't able to wave a magic wand and just get rid of a slum, it might well be that you're obligated to put up a clinic as a sort of patchwork solution under non-ideal conditions. And so this isn't to say that one shouldn't put up a clinic, but it's to say that we have to remember that if you put up a clinic in a situation and you sort of address some of the superficial aspects of what is problematic about that situation, you may disincentivize addressing the wider social problems. Now, here's a way of illustrating the problem with focusing on just the biological aspects or focusing too narrowly on what can be medicalized about a situation. This comes from a story by Joe Nolera from 2010. He introduces a character, a real life person who is a psychiatrist who's very eager to help his patients. But he seems to fail to distinguish between suffering that's rooted in his patients' dysfunctional bodies and suffering that's rooted in their minds and their social contexts. So he has a patient to whom, as it happens, for whom he's prescribed SSRIs to treat depression. And he says to his patient, "How is your medication working out?" She says, "It's working great. I feel so much better. But I'm still married to the same alcoholic son of a bitch. It's just that now he's tolerable." So again, this is a very complex case. It's not to say that somehow this person shouldn't have access to medication. She really is depressed. But in some way, it might mean that by dealing with the symptoms of depression, she's led to tolerate a situation that's fundamentally unjust, whereby she's being harmed or mistreated or disrespected. And you might think that rather than taking a drug to just sort of reduce the symptoms of the problem, what she should do is to leave the relationship. And maybe the medication is somehow actually preventing that or disincentivizing that. So the case of abusive relationships is really very difficult here, because some people don't have the wherewithal to leave an abusive relationship. And relational abuse is something that's, situated within broader sociopolitical concerns and gender norms and so forth. And so if we start to medicalize the harms that can come about in certain relational contexts, just to reiterate the point, this may cause us to lose sight of those sociopolitical aspects that can foster and foment abuse. So Diana Arunke and Christopher McDougall have expressed the point this way: the first and most obviously justified intervention in such a case is not to drug the abused partner into unfeeling, but is to alert the authorities to the violence and to refer her to supportive social and legal services. That seems right. On the other hand, the philosopher Laura Purdy, in an important article on medicalization and feminist medicine, asks whether it's one thing or the other, or whether we might accept the force of the point that was just made, but nevertheless think there could still be a role for medicalization. So she says, these kinds of points imply that women's health, and indeed everyone's health, will be far better protected by political action than by medicalization. But does it follow that women's health should therefore be excluded from the medical realm? Surely not. Because even in the best of circumstances, some proportion of women will require help that medicine can offer, and such help needs to be made available to them. So my colleague Christina Gupta, who focuses on feminist aspects of medicine and technology, makes the important point, and maybe it's obvious, but it's a good point, which is it isn't necessarily either or. It isn't necessarily only that we look at medical solutions or we look at political solutions. She says the individual and the structural, or the biological and the social, are co-constitutive. Interventions that are aimed at the individual may be effective and may have reverberating effects on the broader social issues, and vice versa. So it may be that equipping somebody with a medical technology might allow them to function in their social environment to the point where they're able to actually address some of the wider social issues in some cases. Just to use an example, if you're so depressed that you can't get out of bed and you can't participate in your relationship, or you can't change your situation at all, and it turns out that a drug can help treat the symptoms of your depression so that you can actually get out of bed and engage in the world, that might empower you to grapple with the wider social and structural aspects of your circumstances. So I'm just going to skip over this slide because I want to get into the final points here. Gupta says, I would encourage scholars who are considering the ethics of biotechnologies to address problems that have an individual and a social component, as perhaps most problems do, to emphasize the importance of integrating these individual interventions with social interventions to see how the two might work in tandem to achieve change. And Professor Savulescu and I think that that's the right approach. When we're looking at a complex biopsychosocial problem, we shouldn't just rule out biological interventions, because those biological interventions might have reverberating effects on the psychosocial aspects. But in in putting biological interventions on the table, we must never do so to the exclusion of considering ways in which psychosocial interventions may also be necessary. So Eric Perrins, who's a senior bioethicist at the Hastings Center, an American bioethicist, rightly notes that a blanket condemnation of medicalization would fail to acknowledge the respects in which women and men and people of all genders use medical technologies to gain control over their lives and actually promote their flourishing. And so we wanted to build on this point, and we called our paper The Medicalization of Love to kind of refer to that earlier fear that I mentioned, where we say, our job as ethicists is to try to anticipate some of the specific ways in which these technologies could yield unwanted outcomes, could become serious problems. And by anticipating those potential bad outcomes, part of what we're allowing us to do is to direct the course of the phenomenon in a way that will promote flourishing rather than that will occlude social problems. And so we think it's possible that by thinking carefully through this together, by bringing in different stakeholders, by making sure that we're really being careful and prospective in how we handle these technologies, if medicalization of love is going to happen, we can direct it more toward good medicalization rather than bad medicalization. So that's why we need to have this conversation. We've written this whole book to try to inspire people to have a conversation with us. And so the UK version of the book is on the right, the US version is on the left. It's the same book, just with a different title. And I want to thank you for joining me for this short talk.